Dr. Veronica Piziak, and I am a Baylor Scott and White endocrinologist in Temple, Texas. And we're going to talk today about managing thyroid disorders. My email is on this slide, and if you have questions, you may send them to my email. I have no disclosures for this topic, and we won't talk about non-approved agents. We're going to discuss thyroid disease and COVID-19 briefly, screening for thyroid disease, treating hypo and hyperthyroidism and nodular thyroid disease, and some subclinical thyroid disease. What to do about that? We see a lot of it. When to treat it. Thyroid disease and COVID-19. Well, my patients have asked these questions. I have thyroiditis. Am I more susceptible? No, autoimmune thyroid disease does not cause immunocompromise. Now, some autoimmune diseases do, but not the thyroiditis. I take thyroid replacement. Should I change the dose? The American Thyroid Association says no, but remember to keep your patient's TSH in the normal range, since hypothyroid patients have a decreased febrile response and also a decreased response to some infections. Does the virus affect the thyroid? Interestingly, no. It can cause a euthyroid 6 syndrome that we'll talk about. If you're very sick, your TSH can go up and down and can be inaccurate, but it does not actually affect the thyroid. This is a very excellent question because a lot of viruses, such as HIV, do affect the thyroid, but COVID-19 does not seem to. Now, Dr. Oz says we ought to eat more avocados and avoid cabbage and peanut butter and see if we can improve our thyroid function, but most of us don't think that's true. The American Thyroid Association, for sure, doesn't advocate avocados. Okay, are thyroid cancer patients more susceptible? No, not unless they are on chemotherapy that results in immune compromise, and they very, very seldom are. Those with lung involvement that's extensive may have more problems if they get the infection. The other question was, should they delay surgery or radioactive iodine therapy? No, not except to avoid COVID exposure. You can go right along with that. They do not cause immunosuppression. How about patients with hyperthyroidism and Graves' disease? The American Thyroid Association warns us that any significant infection can precipitate thyroid storm. So counsel your patients on thyroid therapy to take their therapy if they're on medical therapy, and also to get definitive therapy with radioactive iodine and surgery so they can get rid of this disease. Will hyperthyroidism treatment cause an increased risk of viral infection? That's a good question as well. Methimazole, which is our major treatment option for Graves' disease, is a mild immunosuppressant, but should be safe in doses of 15 milligrams daily or less. It can cause agranulocytosis, but at this dose, that's very rare, and it's usually in patients who are older. So your older patients on more than 15 milligrams of methimazole may want to watch them more carefully and see if you can get them definitive therapy. If the patient has a fever or other symptoms with hyperthyroidism, then COVID testing would be helpful, particularly if they are on methimazole. And whenever a patient on methimazole has a fever, they need to have a CBC to make sure they are mounting an adequate response to their infection. Okay, we're going to shift gears and talk about interpreting thyroid function tests. The American Academy of Family Practice said that thyroid function tests are among the most confusing that you deal with. So let's try to look at a little biochemistry. Remember, the hypothalamus produces thyrotropin releasing hormone that goes to the pituitary, which produces thyroid stimulating hormone, which stimulates the thyroid to make thyroxine and triiodothyronine, or T3. Now, T3 is the active hormone and feeds back on the pituitary and the hypothalamus. Most of the T3 is not made by the thyroid. It is converted in the periphery from inactive hormone to active hormone. We want to screen for thyroid disease. You can see the TSH is pivotal, and the TSH is diagnostic of thyroid disease 85% of the time. It is increased in hypothyroidism and decreased in hyperthyroidism. The TSH is not going to be helpful if the patient has pituitary disease, or as we just said before, if they have severe illness. But remember, if the pituitary doesn't work, the TSH isn't going to work. And that's about 15% of your patients. So we said the TSH is very accurate. What happens when the TSH doesn't work? Use the free T4. That is useful. That's the second line diagnostic tool. A total T4 is not very useful. It responds to binding protein abnormalities, which are corrected by the free thyroxine index, but not corrected very well. And frequently, the binding protein is abnormal and not accurate. So it's certainly not accurate in pregnancy and in overwhelming infections, um, in anything that changes the binding protein. So be sure you use the free T4. The T3 is useful if you're following combination therapy and you order a total T3. So if you're using the T3, the free T3 is not as accurate. The American Thyroid Association says we ought to order total T3s. Okay, who to screen? Well, there was a giant discussion about that. And so the American Thyroid Association and the Association of Clinical Endocrinologists and the Endocrine Society got together and they said, screen the high risk population, not necessarily the symptomatic population. Now, if people have symptoms, you can screen them. But on the other hand, be sure you screen these people because they're going to get thyroid disease. Family history of thyroid disease, about 20%. Autoimmune disease, 20 to 30%. Radiation to the head and the neck, about 100% of those people get hypothyroidism. Medications, lithium, amiodarone, ought to be screened. Palpable thyroid abnormalities. If you feel something wrong with the thyroid, be sure that you screen. Atrial fibrillation, dementia, depression, obesity. We all hope we can find the thyroid as a cause and fix it, but that is seldom true. But we always screen those people. Very obese people are more likely to have hypothyroidism, and patients with atrial fibrillation are very likely to have hyperthyroidism. You want to add to your list the people exposed to polybrominated diphenyl ethers. They're endocrine disruptors, and they're people who work in upholstery, in work inside construction sites, putting down carpeting, people who work in the building trade, particularly inside where the ventilation is poor, and the hypothyroidism is more common in these patients. Let's take a look at a few cases. This is our asymptomatic lady. She's a 45-year-old lady brought to the ED after she had syncope. She said she felt fine. She really didn't have any complaints except mild fatigue. Her mother had hypothyroidism, so we would have screened her, right? Right. Okay. Temperature was 97, pulse was 64. She had a delayed reflex relaxation time. That's up is normal, down is slow. And she had an otherwise normal exam. Hemoglobin was 4 and the sodium was 124. So the astute ED physician said, oh, that doesn't look good. Let's look at the thyroid. Her TSH was 116 and her free T4 was 0.6, with normal being 0.96. The free T3 was 1. This lady is very severely hypothyroid and is in danger of respiratory arrest when she sleeps, so we admitted her to the hospital. People with very severe hypothyroidism may be asymptomatic. Their brain is hypothyroid too, and it doesn't tell them they have numbness and tingling and deafness and swelling and they're not thinking very well. It doesn't tell them any of those things because their brain is affected. And so they just sort of pot along and they may not have any symptoms. So what happens when you treat them? You need to tell them for the first couple of weeks, you may begin to notice you have paresthesias. You may begin to notice that you're constipated, that you're just not quite yourself, because it takes about 4 to 6 weeks to get these people back to euthyroidism, and they're going to realize they're going to have some symptoms because their brain wakes up first. So do give them a little chat before you get them on their thyroid hormone to save yourself phone calls. Visit the patient. And you can see around her eyes, she has rings around her eyes. That's periorbital edema. It's very common in hypothyroidism. It isn't bags under your eyes. It's swelling all the way around. You can also see perhaps that her face is a little swollen. Her hair was very coarse, and she has very poor taste in bathrobes. Okay, case 2, well woman exam. So 26-year-old coming for her initial visit. She wishes to become pregnant. She is G1P1 and now on oral contraceptives. She's asymptomatic, but her mother was hypothyroid. And physical exam was okay, except her thyroid was enlarged, firm, non-nodular. She had no palpable lymph nodes. Always check the lymph nodes because lymphoma presents as just an enlarged firm thyroid, but there are always positive lymph nodes. Thyroid cancer can present with positive lymph nodes. So again, check them. What to do? Well, if her TSH is normal, we're going to do anything else? You bet. she had an abnormal thyroid. And whenever your patient has an abnormal thyroid that you feel, a thyroid ultrasound, any palpable abnormalities, a thyroid ultrasound, okay? They're inexpensive. They tell you about the inside of the thyroid. Remember, the thyroid's three-dimensional and you're only feeling the front. And if you said to yourself, oh, heck, I can't feel a thyroid, well, let me tell you what to do. I usually show this, so just bear with me. You know where your sternocleidomastoid muscles are. Just put your fingers on them. You know where your trachea is, right? Put your fingers on that. Go down to the lower third, slide your fingers into the middle, and swallow. What moves is your thyroid. Okay, let's look at the patient's laboratory values. Her TSH is 28, normal's up to 3.74. Oh, she has primary hypothyroidism. Okay. Are you going to treat her? Yes. The ACE guidelines say treating young patients with a TSH of greater than 10 is absolutely indicated. Say if she was 68 and she had a TSH of 10, well, you could still treat her. You want to improve symptoms. She's asymptomatic, but on exam, her blood pressure is 140/96. That's very characteristic of hypothyroidism. High systolic, high diastolic. But the systolic is just usually a bit elevated, and the diastolic is really quite elevated. She also had bradycardia and our delayed reflex relaxation time. Replacement therapy. A brand name is not necessary. Marketed levothyroxine must be equivalent by high-performance liquid chromatography, and it's been that way for multiple years. The American Thyroid Association suggests that we avoid desiccated thyroid or combinations of T4 and T3 because the fixed dose of active thyroid hormone can cause problems. All of us produce variable amounts of T3 depending on our daily needs. In fact, we have a high carbohydrate diet, we produce more. If we're ill, we produce less, and so on. How do you decide how much thyroxine to give? It is a calculated dose. And 1.6 micrograms per kilogram per day is the latest calculation number from the ATA in 2016. Our goal here is a TSH in the normal range, and since she's a young woman, the TSH of less than 2.5 would be what the ACE guidelines suggest. Okay, replacement therapy is increased by medications that speed metabolism. We don't see many of those. Most people aren't on phentoin or phenobarb anymore. But they also can be increased by medications that interfere with absorption, and they are universal, particularly positively charged ions like calcium and iron. Remember that L-thyroxine, levothyroxine is an amino acid, has a negative charge. If you take it with something that has a positive charge, like your milk, it will complex and go right out the back end. You want to take levothyroxine at least 30 minutes apart from any food or beverage. And if you're going to have a huge breakfast, you probably want to wait about an hour after taking your levothyroxine. How about pregnancy? You're going to monitor the TSH monthly during the first 5 months, and you can use the trimester-specific reference range for TSH. But if they're not available, not to worry. Just keeping the TSH at less than 2.5 will do it. In patients attempting to become pregnant, again, ACE says we should keep their TSH at less than 2.5. And the simplest thing to do is just keep all your reproductive people with TSHs of less than 2.5. Used to be an old saw that when the person called you and said they were pregnant, you ought to increase their thyroxine by 25%. If you've kept their TSH to less than 2.5, you may not have to increase it at all. So don't automatically increase it. Get a TSH. TSHs are available in less than 2 or 3 hours in many of our big hospital sites, and at least overnight in most places. The American Thyroid Association says use only levothyroxine in pregnant patients. Women with thyroid cancer who are pregnant should be kept on their preconception pregnancy dose. You don't want to lower that dose. You want to monitor the weight gain, the blood pressure. You want to monitor the fetal changes. And I negotiate with OBGYN. We generally keep them suppressed if they have known thyroid cancer. You don't want a recurrence of thyroid cancer in your pregnancy. They usually do very well as long as the patient and the fetus are gaining weight and the patient's blood pressure can be kept normal, and we generally can do that. It's suggested that there's an iodine supplement should be used in pregnancy because a lot of people are not using iodized salt anymore. Okay, here's a 46-year-old female presenting with fatigue, swelling, tingling of her feet, constipation, thickening of her skin, and amenorrhea. By gosh, she has hypothyroidism, right? On exam, her blood pressure, remember, look at that slightly elevated systolic, the very elevated diastolic, the bradycardia. She weighs 180 and she's 5 feet 2. She has periorbital puffiness, delayed reflex relaxation time. Oops, no goiter. But remember that many people with autoimmune thyroid disease really don't have a goiter, and so don't worry. Look at her laboratory. Uh-oh, that gives us pause. Her TSH is normal. So remember, if the TSH doesn't help you, you get the free T4, and that was low. So what does she have? She has a pituitary problem. She has secondary hypothyroidism to the fact that the pituitary doesn't work. Well, we can see why the pituitary doesn't work. If you're worried about the pituitary, what's the most common problematic hormone is prolactin. Most common tumor, prolactinoma. So we got a prolactin, got a pregnancy test to make sure it was negative, and her prolactin was 536. FSH was 2, cortisol was low, and so she has pituitary wipeout from a prolactinoma. You're going to replace the cortisol first, and then the levothyroxine. How are you going to replace? You're going to use your calculated dose, 1.6 mics per kg per day for replacement, but you can't follow the TSH. Oh, you'd be amazed at the number of people who follow the TSH. Don't do that. It's gone. It doesn't work. If your pituitary doesn't work, your TSH doesn't work. Follow the free T4 and keep it in the upper third of the reference range. We also, of course, treated her prolactinoma. We started cabergoline 0.25 milligrams twice a week for prolactinoma. Okay, our next patient is a 22-year-old lady with ulcerative colitis, chronic diarrhea, and a TSH of 22. Uh-oh, that's pretty high. 3.74 was normal in that system. On 2.0 micrograms per kilogram per day of levothyroxine. Oh my goodness, well, she's taking a lot of levothyroxine. She has malabsorption, so she isn't doing well with her levothyroxine. Now you can increase the dose again, but better yet, use sodium thyroxine solution. It's amino acid solution of sodium thyroxine, and it's in a gel cap, and everybody absorbs it. It just is absorbed like a shot. So when patients are allergic to tablets, when patients have malabsorption, when patients don't have a stomach, sodium thyroxine solution is, or short gut, any of those, sodium thyroxine solution works very nicely, and it has a couple of brands on the market. Okay, it's not about levothyroxine anymore. What about your patients that want to use other medications? The American Thyroid Association says we should discourage them, but I have to tell you, a lot of you say refer to endocrinology. So let me just tell you what to do. Um, This 54-year-old CEO has primary hypothyroidism taking levothyroxine. She feels she wants a more natural thyroid hormone. She has fatigue, weight gain, and hair loss. Okay, fatigue can be either hypo or hyper. Weight gain is generally hypo, and hair loss is virtually always hyper. So she has symptoms, some from column A and some from column B. And when people come with these symptoms that are mixed, I tell them that we may not be able to change all of these, because if we raise the dose, the hair loss gets worse and the fatigue can get worse. The weight gain goes down. But again, you have to tell people right up front that you're not going to be able to fix all these symptoms if there are some from hypo and some from hyper. Okay, she sees you in the clinic. I just told you what to do about talking to her about changing this. The first thing is to check a TSH. If her TSH is higher than 2.5, then just consider raising her thyroid dose. No, it was 1.8. Okay. Alternative medications of thyroid disease. Again, American Thyroid Association says don't use them. Other preparations, pork thyroid has multiple brands, triiodothyronine, which is marketed as Cytomel, that's the only one brand, or combination T4 and T3. Now, advantage of combination T4 and T3 over pork thyroid is that you can personally adjust both the T4 and the T3 to give you optimal levels of each one. Pork thyroid is difficult because you get what you get in terms of a ratio of T4 to T3. Okay, 100 micrograms of levothyroxine is approximately 60 milligrams of desiccated thyroid. And you never want to use the T4 to make decisions about pork thyroid because there's much more T3. So you have to measure the TSH. You use the TSH to make decisions about pork thyroid. If you want to check some other hormone, and patients frequently want you to do that, check the total T3. You want the total T3 in the normal range. You want the TSH in the normal range. The free T4 may be low, but that is because you're putting in pork thyroid, you're measuring pork thyroid, and that the ranges for T4 and T3 are different from the pig rather, and the human. Okay, here's a 44-year-old lady on dialysis Monday, Wednesday, Friday with multiple hospitalizations for severe hypothyroidism. This is the third time I'd seen this lady. Her TSH was 252 on admission. If you stop and start and stop and start your thyroid, your TSH can become exponential. It really keeps going up and up and up. You can actually develop a tumor of the pituitary of the TSH producing cells. So she was kind of on and off and on and off. Her free T4 was 0.6 and 0.74 was normal at that time. Total T3 was low normal, and you're consulted for myxedema coma and asked what to do to prevent the problem from recurring. She says she just doesn't remember to take her thyroid. Okay, this is a question. I'll just run through it because the answers tell you a few things. Yes, she has myxedema coma. Give her 200 micrograms of T4 slow IV push, 1/2 to 2/3 of her calculated levothyroxine IV until taking PO, and then put her back on her usual dose for discharge. That, by the way, is the way you treat myxedema coma. So you could just put that down in your notebook for treatment of myxedema coma. But in fact, as we told them, she was talking to us, so she wasn't in coma, and her T3 was normal. So just restart her 100 micrograms and tell her to have her phone remind her to take it. She doesn't have an iPhone and she's a little demented. She is a danger to herself. Put her in an ECF. She doesn't want to go into an ECF. She's really doing pretty well at home. She just can't take her thyroid. So the ACE guidelines suggest if you have a patient who can only intermittently take her thyroid or only intermittently can be given her thyroid, then multiply the total, multiply the daily dose by 7, get the total weekly dose, divide it by the number of times you can administer the thyroid and give that. So we said she's going to take 700 micrograms a week. She'll take it when she goes to dialysis on Monday, Wednesday, Friday, and the dialysis nurse is very graciously giving her 225 micrograms 3 times a week. And her TSH goal is less than 10. But in fact, her TSH is now normal thanks to the dialysis nurse. Is this Graves' disease? It's a 17-year-old lady who's 6 weeks postpartum, and she has weight loss, nausea, diarrhea, and muscle weakness. Ooh, that sounds like hyperthyroidism. On exam, her blood pressure is 150/60. Now look at this. Hyperthyroidism gives you a high systolic pressure and a low diastolic pressure. You get high output cardiac failure and rapid cardiac arrhythmias like AFib. Pulse rate is 100. She's 92 pounds and 5 feet 6. Oh, she is really thin. She has no signs of bulimia. Remember, that can mimic Graves' disease. Thyroid is normal size and non-tender. TSH is a little low, and the free T4 is just a touch high at 1.48 with 1.46 being normal. Someone astutely did an I-123 uptake, and it was 2%. So it was low. So she has thyroiditis in the hyperthyroid phase. Okay, hyperthyroidism in the patient with thyroiditis. Remember, the thyroiditis just is an inflammation of the thyroid, and you have uncontrolled release of thyroid hormone out into the bloodstream, and so you just get a hyperthyroid phase. The laboratory frequently doesn't correlate with the symptoms because once the hyperthyroid phase is over, you go into the normal phase, but the laboratory may lag behind. And then The iodine uptake may also not be very good because it's high in the recovery phase. So, hard to diagnose thyroiditis. It used to be hard, but now, thyroiditis, how to make the diagnosis, the ultrasound, no radiation exposure, really inexpensive. Ultrasound shows a very characteristic heterogeneous pattern. The anti TPO antibodies are frequently high, and so if you're going to get an antibody, that's the one to get, but they're not always high. And so if you're not sure of the diagnosis and you think, oh, the patient's hyperthyroid, I don't know if they have Graves' disease or thyroiditis, get a TSH receptor antibody. It's positive in Graves. It's generally highly positive in Graves. Thyroiditis, remember, resolves spontaneously in about 2 or 3 months. It may recur, but it does resolve by itself. Graves' disease does not resolve by itself and really needs aggressive therapy. In thyroiditis, you're going to treat the symptoms. So if they have pain in their thyroid, which is frequent, you can treat with a buffered aspirin, some NSAIDs, tachycardia, low dose beta blocker. And if they're very symptomatic, have a lot of pain, then you can use a short course of steroids, something just a dose pack would be fine. And you want to follow until the TSH is normal. And then you want to follow at 3 months because the thyroid may fail. And about 20% of these people develop hypothyroidism if the thyroiditis is severe. And if you only follow till the TSH is normal, you're going to miss it. So TSH is normal, another TSH in 3 months to make sure they didn't have thyroid failure. If they have multiple recurrences, you may want to consider surgery. Okay, this is a 28-year-old lady with the diagnosis of Hashimoto's thyroiditis on replacement levothyroxine. TSH is 1.8. Free T4 and total T3 are normal. She has fatigue, myalgia, hair loss, dry mouth, and sleep disturbance. She wants her thyroid removed because her autoimmune disease is making her sick. Do you think that will help? Well, first, remember, make the TSH less than 2.5. The TPO antibodies are normal. Tell the patient, look for another cause of symptoms. It is not your thyroid. If your TSH, free T4, and total T3 are normal, the TPO antibodies are normal, it's not your thyroid. You can do a thyroid ultrasound to look for nodules and enlargement. If they're not there, it really isn't your thyroid. So you just, be upfront with people. Tell them it's not their thyroid. I know that's hard, and you have to look for other causes of these things, but it's the best management. How about thyroidectomy for thyroiditis? Is autoimmune disease really disabling and uncomfortable? Yes. If your TPO antibodies are greater than 1,000, you can be symptomatic just from your autoimmune disease, even if your thyroid is functioning normally. But the TPO antibodies have to be greater than 1,000. And they actually looked at this. They randomized these groups and they did thyroidectomy versus medical management. They found that fatigue, quality of life, and obviously TPO antibody is reduced in the surgical group. So, yes, if you do have overwhelming autoimmune disease, even if your thyroid function is normal, you could benefit from surgery. But otherwise, the TPO antibodies are oh, less than 1,000. Really shouldn't consider it. Okay, here's a lady with a 50-year-old lady with hair loss that found on the internet that biotin could be helpful. She takes no other medication. She started on 10 milligrams of biotin, which is 300 times the recommended dose. And 3 weeks later, she went to the ED with dizziness, a pulse of 76, a blood pressure 100/72, no thyroid bruit, no lid lag, normal EKG. Uh-oh, her troponin was elevated. Her TSH was 0.2, so that was a little low. Free T4 was 1.5. That's a little high. Well, maybe she has hyperthyroidism. Aha, this is another question for you. What should we do? Admit to the ICU for NSTEMI? Start methimazole and a beta blocker for hyperthyroidism? Stop her biotin and repeat the lab in 10 days? Consult Dr. Oz. Dr. Oz, by the way, is a um, person who is on the media, and he will tell you all about the thyroid. He is the world's media expert on thyroid. So I wouldn't suggest number 4. And in fact, they consulted endocrinology and cardiology, who both suggested number 3 because both troponin and the thyroid function tests are affected by high dose biotin. And there you have it. She was taken for cardiac catheterization, and they thought she might have arterial spasm, but we convinced them that stopping the biotin would do it. And her retesting showed that both her thyroid hormone and her troponin were normal. So when your patients are on high dose biotin for their hair, they need to stop it for 7 days before you check their thyroid, because the biotin interferes with the assay. It doesn't do anything to the thyroid, just interferes with the assay. Okay, let's talk about subclinical thyroid disease. You see a lot of that. And the ATA says treat the TSH, treat the thyroid if the TSH is 10 or greater. You really ought to treat. But if the patients are over age 60, the TSH can be up to 6.5. That's probably pretty normal. What you're going to look at here is the free T4. If the free T4 is normal, you are not obligated to treat the patient if they don't wish to be treated. If they feel better. I have a number of people who just don't feel very well on levothyroxine that keeps their TSH at 2 or 4 or even 6. And as long as it's 10 or less, there's no consequence to not treating. That's the American viewpoint. The British viewpoint is down here, and it says, hey, there's no consequence to not treating if the TSH is up to 20. And so they say 20 is okay. If you're 25, probably not. I'm sorry, there's a typo on that slide. But at any rate, unless the patient is young or trying to become pregnant or has symptoms, you can tailor the therapy for subclinical hypothyroidism to the patient. Now, you probably should treat people who are likely to progress to hypothyroidism, particularly if they're symptomatic. If they have TPO antibodies of 536 or TSH of 7, they're probably going to become hypothyroid. Chronic renal disease. The subclinical hypothyroidism decreases your estimated glomerular filtration rate. It decreases your kidney filtration, so you ought to treat. And of course, pregnant patients with positive TPO antibodies, you should treat. And obviously, people with symptoms. Now, this is a 72-year-old lady with angina and tachycardia on amiodarone. TSH is 15, and she has subclinical hypothyroidism. Her free T4 is 1.2. Her ejection fraction was 58, and that was good. And so for this lady, what our goal is not a normal TSH. Our goal is a normal ejection fraction, and she was in good shape. So we said, okay, we're going to watch this. But she's on amiodarone, and so we're going to watch carefully because she probably is going to progress. So we monitored the TSH and the free T4 in a month. Uh-oh. That's a little amiodarone in high dose. If your TSH is over 10, really can result in hypothyroidism pretty rapidly. So she had a TSH of 30 and a free T4.06, and not only that, unfortunately, she had an ejection fraction of 30. So if you're watching the people on amiodarone and they've gotten to the point where the TSH is 10 or more, you probably ought to treat them. The problem is she had angina. We're very worried about treating her. So in the patient who has angina, start a tiny dose. We started 12.5 micrograms a day, and we titrated it up. And what did we monitor? Well, we monitored the free T4, which had gone down, of course, to get that into the low normal range. And we also monitored the ejection fraction. And what you're trying to do here is improve the ejection fraction. You really don't give a hoot about the TSH in this case, except that when it's over 10, you got to watch very, very carefully. Okay, these two people have symptoms of thyroid disease. 76-year-old male with urosepsis, and his TSH was low. His free T4 was upper limit of normal, but it was normal, right? And his free T3 was low. 18-year-old lady with DKA, TSH was 6.25, which is high. Free T4 is 1.38, upper limit of normal, but it's normal. And the free T3 was 1.2, which is low. So again, low T3, normal free T4, and the TSH is up and down. So what do these people have? They have euthyroid 6 syndrome, and the free T4 is the key. It is generally normal. The T3 is almost always low, but that takes longer to get back, and you want to make sure you're getting the total T3. These people didn't, but hey, it was their case, not mine. In severe acute illness and some chronic diseases, the T4 is not well converted to T3, and there's a defect in the hypothalamic pituitary adrenal axis. So the patient can look like they're hyper or hypothyroid from the TSH. So you want to get the free T4 in those cases, and you just recheck again. There's no when they're not ill. Okay, so how about subclinical hyperthyroidism? Part of the time, the circulating hormones are elevated. In younger patients, this is virtually always thyroiditis. The TPO antibodies may be elevated. The ultrasound is generally heterogeneous. But in older people, it's frequently a multinodular goiter, and you must obtain an ultrasound. The patients over 50 is a disservice if you don't get an ultrasound in these people, because they can have a multinodular goiter. And a multinodular goiter, remember, is more likely to cause sort of dwindling in the older patient. It causes just borderline hyperthyroidism that results in atrial fibrillation, ventricular fibrillation, and death. And you may miss it if you don't get the ultrasound. The level of TSH here determines whether or not you're going to treat. TSH 0.1 to 0.045, really nothing much. No treatment is recommended. Follow yearly, but remember to get the ultrasound in the people with the older people. TSH is less than or equal to 0.1. You really, particularly for patients over 60 years old, you need to treat because of the increased atrial fibrillation chances and vertebral fracture. Don't forget the ultrasound. It's incredibly important in these people. Okay, if we look at overt hypothyroidism and subclinical hyperthyroidism, which are the two top lines in that graph, you see that the risk of atrial fibrillation is exactly the same in overt hyperthyroidism and subclinical hyperthyroidism. So once your TSH is 0.1 or less, there's a controversy about 0.1 or a little less, then you have a problem. Mass effects from the thyroid. I met this lady when she had tracheitis on the ED, and they couldn't get they couldn't get a tube in. They said, "Oh, we need a tracheal tube. We can't get it in." So they called endocrinology, and I said, "Oh, no. You need to have called surgery." Yes, thyroid nodule can cause mass effects, but long before we get to this lady, your patients with multinodular goiters can have difficulty swallowing. That's one of the first signs that you're having problems. Or you may see tracheal compression on the chest X-ray. So remember, ask about difficulty swallowing in these people. We didn't have to ask this lady. She definitely had difficulty swallowing. So how do we treat? Antithyroid medication, low dose methimazole, 5 milligrams BID. Some of my patients are on 5 milligrams a day. These multinodular goiters respond to very low doses of methimazole, and the goal is a TSH in the mid-normal range. But again, these are older people. You want to make sure you discuss the possibility of neutropenia and a granulocytosis in this group, even on low dose. And also discuss the remote possibility of liver dysfunction with methimazole. Methimazole has never been shown to cause liver failure. Propylthiouracil, which is the other oral thyroid drug, antithyroid drug, can cause liver failure, and that's why virtually nobody uses it anymore. You want to use methimazole, and again, discuss liver dysfunction. If the patient develops liver dysfunction, they stop the methimazole, the liver dysfunction goes away. Okay, our last type of patient is a patient with hyperthyroidism. She's a 22-year-old lady with Graves' disease for about a year. For 12 weeks, she's had weight loss, her heart's been racing, she's had diarrhea and tremor and severe muscle weakness. Her husband brought her in because she just couldn't get up off the floor. That should say from the floor. You don't notice your typos till they're huge on the screen. And she just couldn't get up. She was down with the kids, just playing with the kids on the floor, couldn't get up. Blood pressure is 90/60, pulse 130, but luckily regular. Proptosis, extraocular movements were intact. Remember, always look at the extraocular movements. One of the first things to go in severe Graves' disease, and you can get, if you get inflammation of the extraocular muscles, and you can get permanent scarring, and then the patient has prisms, and they have to have surgery to reimplant the extraocular muscles. So you want to notice that right away. Her thyroid was enlarged and she had no palpable nodules. Her lungs were clear. She had red palms. She had palmar erythema. That's a palmar erythema and tremor, really signs of significant hyperthyroidism. And she also, of course, as we said, had significant proximal muscle weakness. Laboratory TSH was undetectable. Free T4 was 8. Our upper limit of normal is 1.46. And her free T3, I know they should have gotten a total T3, but they didn't. Her free T3 was 16 and normal was 4.6. So this lady, because she has a high free T3 and she was a smoker, was more likely to develop eye disease. When the patient with Graves comes to your office, one of your first questions is, do you smoke? And if they say yes, you say not anymore, because eye disease is so much more common in the smoker. And this is how she looked. You can see from the arrow that the arrow is pointing to periorbital erythema, which is an ophthalmologic emergency because it means that there's swelling in the orbit. It can compress the optic nerve, force the orbit forward, and cause blindness in a short period of time, in days to weeks. So these people need to get right over to the ophthalmologist. The extraocular movements are not intact. They need to get to the ophthalmologist right away. Okay, looking for complications. We just talked about eye disease, extraocular muscles, proptosis, tachycardia with low blood pressure. Very problematic. They can develop cardiomyopathy and they can develop cardiac arrhythmias. Proximal muscle weakness, dehydration. You want to avoid that. You can get acute kidney injury with hyperthyroidism. When are you going to hospitalize? The patient has vomiting or inability to take their medications properly, because these are oral medications. the antithyroid drugs do not come in IV form. You can use rectal suppositories, but they aren't very well absorbed. Or anytime the patient with hyperthyroidism has a fever, because they could have thyroid storm, and that has a 50% mortality, even now with excellent intensive care. That's why you need to keep all of your Graves' disease patients in reasonably good control and emphasize that they need to get definitive therapy. Okay, treatment for this emergency: hydration. I made sure she could take oral fluids, and we did hook up an IV actually in the clinic. Beta blocker, non-cardioselective. Endocrinologists favor propranolol, and they favor short acting because the patient can regulate it themselves. But you can use long acting if you like. Other beta blockers work. We like one that crosses the blood-brain barrier because it helps calm people down. And anti-thyroid drugs. This is Graves' disease, methimazole, up to 60 milligrams a day. They're going to need more. They're probably going to need to start on 10 or 20 or 40, depending on how hyperthyroid they are. But you're safe with 10 twice a day if you're worried. So you see one of these people in your office, you say, I'm going to send them to endocrinology. I can't get in today. I'm going to use propranolol, and you start something like 20 milligrams twice a day. Simple. Or you can use methimazole, and you can start 10 milligrams twice a day. Just pick a low number that will help the patient out, and it helps prevent thyroid storm. Okay, dexamethasone. If the patient has very significant muscle weakness, like she did, just low dose dexamethasone, 2 to 4 milligrams BID, decreases the conversion of T4 to T3. And be sure you get definitive therapy for these people. Don't let them just wander off on their medications, because Graves doesn't go away. And even if you have a remission on the medications, about 30% chance of remission, it comes back. Okay, do I have cancer? Well, this is a lady who went to something I would really like to shut down, ultrasound of the carotids at a health fair, and she had a thyroid nodule. So what are her chances of having cancer? She's on the phone. She wants to know. Oh, about a 5 to 7%. If her family had cancer, about a 15%. So you can reassure her that they're not tremendous. And if her thyroid nodules were less than a centimeter, they're not clinically significant. They don't give you cancer. If you find a thyroid nodule on a PET CT when you're doing it to look for metastases of a malignancy, it's probably malignant. It's either a thyroid cancer or a metastasis. The malignancy rate is higher in children and men, or if you have a positive family history. And obviously, if you feel a whole hard, palpable neck nodule with lymph nodes, it's probably malignant. How do you manage thyroid nodules? Well, if you want to biopsy them yourself, you can, but we need the money. So if you don't biopsy them, send them along. Please get a TSH. So if it's normal, we're going to biopsy. If it's elevated, replace the thyroid hormone. There's no problem doing that. And a lot of times those nodules, they're just Hashimoto's nodules, they just disappear. The only time you have to do anything else other than get the TSH is, or replace the hypothyroid person, is if the TSH is suppressed. And then you're going to measure a free T4. If that's normal, we're going to biopsy. But if it's elevated, that is the only time you're going to do an I-123 uptake and scan because you may have a toxic autonomous nodule or Graves' disease plus a nodule. You can get a TSH receptor antibody. They'll tell you about nodule, but we're still probably going to biopsy at that if the patient has Graves'. But again, only time you get an I-123 uptake and scan is when the TSH is suppressed, the free T4 is elevated, and you're wondering if you have a toxic autonomous nodule, which means that only the nodule is hyperthyroid. The rest of the thyroid isn't. And thyroid cancer guidelines, you're going to be following up some of these people because there's a lot of thyroid cancer and most of it is cured, and they're free of disease. So you measure a thyroglobulin and a neck ultrasound. That has essentially replaced the I-131 body scan, particularly for low risk patients. We order the body scans sometimes, but really all you need to follow is the thyroglobulin and the neck ultrasonography. Thyroglobulin is up. I would suggest you refer them to endocrinology or oncology to evaluate that. Sometimes they use an I-131 scan. But you're going to be following a lot of these people. If the patient is free of disease and they're low risk, then the TSH should be low normal. You don't have to have that suppressed. Persistent disease, we usually keep these people just because it's very difficult to get the scans. It takes a lot of time and energy to get those approved, and so we keep them. But again, you're going to see a lot of these people who are either cured, and then the TSH can just be in the normal range, or they're free of disease and low risk, and the TSH can be in the low normal range. Okay, in summary, what are the replacement goals? In primary hypothyroidism, we want a normal TSH. In reproductive age women, less than 2.5 is good. Secondary hypothyroidism, you want a normal free thyroxine, usually the upper third of the reference range. Subclinical hypothyroidism, use your clinical judgment. You know, if the patient is older, the TSH can be higher. If the patient is symptomatic on replacement, they can have a TSH that's a little higher. So tailor that to the patient. You'd like to keep the free T4 normal. Subclinical hyperthyroidism, determine the cause. And if the TSH is less than that should be, I'm sorry, that is a typo 0.1 to prevent complications. And remember the ultrasound in the patient with the nodular goiter. So TSH 0.1, not 0.1.